This lecture is going to be on power scaling and aspiration and evacuation. So there are different types of power scaling. So we are going to learn about ultrasonics and sonic scalers. So both of them are power-driven instruments, and they work by taking electrical currents or compressed air, depending on if we're talking about an ultrasonic or sonic, and they turn that into a high frequency sound wave. That high frequency sound wave is then going to produce vibrations, and that is what is going to make our instrument work. Now, they're all going to work different ways, and we're going to learn about the tips that are available for them, how they work, and which patients we should use them for. Okay, so as far as ultrasonic scalers, there's different brands. Now in the clinic, we have cavitrons. So we have little cavitrons in every unit, but though that is not the only company that makes them. So there's just a list of different ultrasonic scalers that are available. Now the variation between these, they work by different methods of how they convert that electrical energy into mechanical vibrations. There's also a difference in how the tip moves, so the pattern of tip motion. We can break that down to amplitude and frequency. So amplitude is going to be the length of the tip movement. Frequency is going to be the speed, so how fast that tip is moving. And obviously an ultrasonic scaler is going to move faster. The tip is going to move faster than it would on a sonic scaler. Another difference is the number of surfaces on the tip that is active. Okay, so if 100% of that tip is active, then our angulation can be, a little bit easier. If only the lateral surfaces, then we're going to need to use that instrument more like a hand instrument, okay, because not all of it is active. Okay, so what is the purpose? A lot of times we will use these ultrasonic or sonic scalers for periodontal debridement. So if you have a patient that has deep pockets, they have a lot of calculus, they have areas that they are not getting clean well. The frequency, the bubbles, the water is going to help us lyse that bacteria and help make that pocket healthier. Okay. It's also going to help us remove tenacious calculus and stain. So really hard calculus is going to be hard on our hands to remove. Stain is going to be hard on our hands to remove. So if we use the ultrasonic scaler, that's going to help our hand scaling. It's also going to disrupt that biofilm. So like I said, it's going to lyse those bacteria cell walls. If we lyse them, it's going to kill those bacteria, and therefore they can't keep reproducing and colonizing like you learned in perio. Okay? It's also going to be able to remove diseased tissue. And so sometimes if somebody has a severe perio and there's a lot of disease and a lot of bacteria in that tissue, you'll see some of that tissue sloughing off as we use our ultrasonic scalers. Now the mechanics. So how do they work? So the ultrasonics, their frequency, so their vibrations are going to be in the range of 25,000 to 50,000 cycles per second. So that is really fast. Obviously, we're not going to be able to visibly see that movement, okay, but it's really fast. There's two different types that we're going to learn about. We're going to learn about our magnostrictive ultrasonic scalers, and we're going to learn about our piezo ultrasonic scalers. Now, we use mostly the magnostrictive in our clinic, but I also have piezo units and piezo tips in our clinic as well. Now the sonics. The sonics are going to have a frequency of 2,500 to 7,000 cycles per second. So again, that's fast, right? But not nearly as fast as our ultrasonics. So we will use exclusively sonics, ultrasonics in our clinic. We don't have any sonics that we're going to be using. So what they do is they attach to a high-speed handpiece, and that is what's going to produce that movement of the working tip. Okay, so magnostrictive versus piezo. Magnostrictive is what we're going to talk about first. So here's just a picture of a unit. We have some of these, and then we also have a smaller unit that's about half that size, and it only has a power dial, and the water dial is on the handpiece. Now there are a million different types of tips that we can use. So there's going to be tips that are going to be for mesial. There's going to be tips for distal. There's going to be tips for lingual. There's going to be tips for facial. There's going to be universals, so we can use them wherever. And if you notice that some of these tips have two lines coming out of them, or two little metal pieces, that just means it has an external water source, so the water comes through that and drips onto the tip to keep it cool. Now, if you notice those ones down at the bottom, they only have one metal tip coming out of there, and so they have a little hole on the inside of that, which you can't see really well from this picture, but that hole is where the water comes out, and it continuously cools that tip. So we always need to make sure that we have water coming out of our instrument. Okay, so it also needs to be water in between that tip and the tooth, because sometimes it's not the tip that's going to get hot, but it's the friction of the movement against the tooth surface that's going to get hot. And yes, we can cause pulp damage if we heat up that tooth too much. There's also tips for implants. There's all kinds of different tips, and we'll look at some different ones. I've picked 3 for your kit, and those are pretty universal ones, and those are the ones that you will use in clinic. And there's also ones for supracalculus. There's also ones for subcalculus, and they're basically just designed for the area that we want to use them in. Now, our magnostrictives, they're going to use a stack of flat metal strips. And when you look at those, so when we open your tips, you're going to see the tip, and then you're going to see that long coils of magnets coming down. We have to be very careful with those. I don't ever want those magnets getting bent. So that information has to go up and down and up and down and up and down those coils. If there's a bend, or if they are not touching anymore, okay, that your tip is not going to be as active as we want it to be, which is why I have you guys buy a special case with a liner inside of it that helps keep that metal strip from getting damaged. This unit is then going to be attached to electricity and water, and then we are going to run it with a rheostat, just like you do when you polish. Okay, so how do they work? They work by the method of converting energy into vibrations by way of a transducer. So when the electrical current is turned on, a coil in that handpiece becomes magnetized. So vibrations from that magnetized strip are going to be passed through a transducer, and that is going to be what makes that ultrasonic tip work. So what is this pattern of action? Generally, the pattern is going to be elliptical. What's nice about our magnostrictives is the number of activated surfaces is all of them. So the entire thing is active. So as long as some part of that touches calculus, it should start to break it up or shatter it. The tip shape then in general is going to be cross-section of the tip is going to be round. Okay, now our piezoelectric. Piezos are going to be a little bit more powerful than our magnostrictives. Okay, they don't use that magnet strip or stack like our magnostrictives do. What they have is a ceramic rod, and that ceramic rod is going to be completely contained within a handpiece. Okay, and I'll talk about how that works in just a few minutes. So the method of converting energy into vibrations, so that alternating electrical current is going to be applied to quartz or metal alloy crystals within that handpiece. So basically the electrical current is going to cause those crystals to change in dimension. So basically they're changing in size and they're changing in shape. This rapid change is what is going to cause our vibrations, and that is going to be what it makes our tip active. So our magnostrictives are going to use the magnets. Our piezos are going to use this quartz or crystals, metal crystals. Okay. And again, those crystals are just going to change in size and shape. So the dimension of them is going to change. This rapid change is what's going to cause that tip to work. Now their pattern of action is different. It's going to be linear. Okay, so linear back and forth, not elliptical. Magnostrictive was elliptical, right? So elliptical is more around. Now the other more difficult thing with our piezo is only the lateral surfaces are active. So you have to have more proper positioning with the piezo, because you have to have that lateral surface touching the calculus, because an ultrasonic scaler will not remove calculus if it doesn't touch it. Okay, so operator error. If you're not touching it, you're not going to remove it. So obviously with only two sides of the lateral surfaces being active, it makes it a little bit more challenging to use. Okay, but it is more powerful. Now the tip shape. The cross section of the tip is going to vary. So there could be many different, it could be trapezoidal, it could be round. So it's going to be different by what tips you use. Now our sonic scalers. These are usually only available in standard diameter tips, which again is going to limit our access. So our ultrasonics, we saw that there are tons of different tips. So your tips for your sonic scalers are going to be much more limited, and they are going to be simply threaded onto a handpiece. So how do they work? They work by using compressed air, and it's going to be forced through a hollow rod into a handpiece. So just like when you're polishing, right? You put your polisher on, you push Profi angle on your slow speed and you polish. Okay, so that compressed air is going to be passed over a series of metal plates, and it's going to cause vibrations that are going to be transferred to that sonic tip, and that is what's going to cause it to move. And the water flow is going to be through the handpiece, and it's going to come out a hole near the end of the working tip. And obviously we need to make sure that our lines are clean, but we do that here in clinic, right? We dry our lines every night, and we make sure that we keep our biofilms down to a minimum. So for these, water is not going to be needed to keep the tip cool, but it's going to help with lavage. Now, lavage just simply means the water that's coming out is going to flush. It's going to rinse out the area. So once we start using these, we're going to see chunks of calculus. We're going to see some bleeding. It makes our visibility difficult, but that lavage helps. So that clearing away with the water is going to help us see when we're cleaning. So water is going to be required to cool the friction then between the instrument tip and the tooth surface. So never use these instruments, whether it's sonic or ultrasonic, never use these instruments without water. In the sonic scalers, the pattern of action is going to be generally elliptical, and the number of activated surfaces, again, is all of it, 360. Okay. So frequency, though, cannot be adjusted by the operator. So we'll see with our piezo and we'll see with our magnostrictive that we can increase the power, we can decrease the power. So certain tips we're going to use a higher power, certain tips we're going to use a lower power. Okay, we don't have that ability with our sonic scalers. We just have our rheostat. So the frequency cannot be adjusted by us, the operator. Let's talk about ultrasonic inserts or tips. There's thicker tips, there's smaller tips. So the thicker tip we refer to as our universal, and we are going to use it to remove heavier deposits. And we need to make sure that we have the instrument on at least medium to higher power. So it's not going to work as well if we have that on a lower power. Our slim tip, this is going to be our perio tip. So this is going to get down into deeper down in the pockets. And we're going to use it more for the removal of fine deposits and to disrupt that biofilm. It's going to be best on no higher than medium power. Okay, if you turn this up past medium power, there is a chance that that tip can break, and I've seen it happen. So make sure that you're paying attention to your power and which tip that you are using. Now there's many different designs, but none of them have any cutting surfaces. Okay, so cutting surfaces are just for your hand instruments. These only work by their mechanical vibrations. Okay, so they're designed to be worked, like I said, in singles or in pairs. So it could be like your Gracies, you know, and you could have one for the mesial, one for the distal. Okay. So the insert has a working tip and a transducer, that magnet stack, which slides down into a handpiece. So the tip is round and smooth. Okay, and like I said, that water is going to either have an internal or external source. So external is where we saw the two metal tips coming out of the handpiece. And then the internal is you just have the one and there's a little hole in it, and that's where the water is going to come out. The maximum power is in the very end of that. The last 2 to 3 millimeters of that tip is where you're going to have the maximum amount of power. The working tip for your sonics, then the working tip is just going to be threaded onto a handpiece. It may be round and smooth, or it may have 4 edges, but like I said, you're very limited to the tips you can have with those. And so we just don't really use sonics very often when we have the capability of using ultrasonics in the clinic. So here's just some different names of tips. So the beaver tail is going to be, just like the name entails, a large, wide tip, and it is going to be used only supra, and is usually going to be used in section 5. So it would be very difficult to adapt this tip subgingivally. Okay. Then you're going to have your slimline, you're going to have your chisel. There's what's called triple bends. There's specific ones made to get into a patient's furcation. All of yours are swivel, and I'll show you what that means when we start working with them. And it just means that it turns. You're able to swivel your tip. So it just makes our adaptation easier. Okay. And then there's different ones called after 5, diamond coated, ultra thin, implant ones. Many, many, many different tips. And again, here's just some pictures. Okay, so that one down on the bottom right is going to be your beaver tail. It's that large, thick tip, so we would never go subgingival with that. Right above that is going to be one that's going to be a right or a left, right? So it's going to be either a mesial or a distal. So it's single use. And then the one in the middle on the bottom, that's going to have your external water source. So if you see, it has the 2 metal tips coming out. So the top one, the small one, is just going to be used strictly for water coming out to stay on that tip. Now, what is the purpose of all this water? Well, one, we want to keep the instrument cool. We want it to keep flushing all that debris away, so it makes it easier for us to see. But we also, your patient gets a benefit from what's called cavitation. So cavitation basically destroys that bacterial cell wall, and it disrupts that biofilm. So as far as cooling the tip, so it's going to help control that heat production. It's going to prevent damage to our pulp. We do, though, never stop moving the entire time we have the tip activated. We want to constantly move, move, move. You'll hear me say sweep, sweep, sweep. So we constantly want to keep that tip moving constantly. If you leave it in one spot too long, it can heat that tooth up and we can cause damage to the pulp. Another purpose is it's going to flush that debris away. So it's going to go down to the base of that pocket. It's going to flush out that calculus. It's going to flush out that debris. It's going to destroy all of that bacteria. Okay. It's going to be much better for our vision. And we're going to use a very light touch. So tactile sensitivity, very light touch. You don't want to hold on to this instrument hard. You want to hold it very lightly and let it do the work. So the harder you hang on to it, the harder you press it up against a tooth, you're going to stop some of those vibrations. So if you use a very light touch during your instrumentation, you're going to get the best benefit of that instrument. Now cavitation. So cavitation destroys or lyses those bacteria cell walls. So as we know, we've got gram-negative bacteria down in those pockets. It's very sensitive to our ultrasonic instrumentation. So what happens is it's when that bacteria cell wall is lysed, so when that's destroyed, they're going to release endotoxins, which luckily our lavage is going to flush right out of those pockets. Okay, we don't want to leave that bacteria or those endotoxins down inside there. So how is cavitation created? So cavitation is created by the formation and collapse of bubbles in the water by that high frequency sound waves during that ultrasonic motion of the tip. So what happens is it makes those bubbles, it collapses those bubbles, it makes those bubbles, it collapses those bubbles, and the cell walls don't like it. So the formation of partial vacuums in a liquid by breaking those bubbles and high frequency sound wave causes that bacterial cell wall to lyse. And that's what we want. We want to destroy all that. And then we want the water to flush out all of those endotoxins that the bacteria are leaving behind down in the pocket. Okay. It also leaves the mouth feeling much cleaner. So a lot of patients love the ultrasonic cleaner. Now, some patients are going to hate it, but in general, most patients do like it. So if insufficient water is used, though, to reduce heat, or the instrument is held in an area for more than a few seconds, that temperature can rise in that pulp chamber, and we do not want it to damage it. So we need to constantly keep moving. Always make sure that your patient has water. So make sure that water is continuously coming out. So also the type of sensitivity is going to be determined on the amount of water desired. So you need to know what type of sensitivity your patients have. So is it sensitive to hot? Is it sensitive to cold? Is it sensitive to vibrations? And so that's going to make a difference on how you make that patient comfortable. Now, our water's room temperature, so at least, you know, it's not cold water, because we have self-contained units. So our water's just in that bottle. So it stays at, you know, room temperature. So we can't really change the temperature of our water, but we can increase the water, we can decrease the water, we can turn up the power, we can turn down the power. But again, all of that is going to also determine on what tip we are using. So infection control. These instruments, whether it's ultrasonic or sonic, are going to produce aerosols. So we have to make sure that we keep ourselves we need to be careful with ourselves as well as our patients, as well as other people that are in the clinic. Because if I'm using the ultrasonic with my patient in clinic and I have other patients walking around without a mask on, we're making those aerosols, and those patients are breathing them. So we want to make sure that we wear our proper PPE. So we're going to wear our mask, and if it gets wet, we're going to change it. We're going to wear protective eyewear, face shields maybe if you want to wear a face shield, gloves, and then our disposable gown. Always, always, always have your patient do a pre-procedural rinse, and always make sure it's an antimicrobial rinse. So a fluoride rinse, an anti-cavity rinse, not going to cut it. You have to read the bottle, make sure it says antimicrobial. Okay, so always have your patient do an antimicrobial rinse before you use the ultrasonic scaler. And in our clinic, since they're so long, if you have the patient do a pre-procedural rinse, say possibly when they first sit down, and you don't ultrasonic for another hour and a half, have them do the pre-procedural rinse again. Okay, it's not going to hurt anything. It's just topical. They're swishing with it and spitting it out. Make sure your patient has protective eyewear on. And also make sure that you have a drape over them. So a drape is going to be, we can use a garbage bag. I have some plastic drapes. Water is going to drip. We don't want our patients to get their clothes wet. So make sure you put a drape, and we'll put the bib on top of that. For as far as infection control, if we can use the HVE, that is the best. It's best if we have an assistant. Okay. So you can flush the water line at least 2 minutes before using at the beginning of the day, 30 seconds between patients. So that is if you had water that is not self-contained. So if you work in an office where you don't fill a water bottle, so you just have like city water coming into your unit, then you need to make sure that you do this. So you'd flush for 2 minutes and then flush for 30 seconds. Our water is contained. Okay, so we don't have to flush between. We dump our water, we dry our lines, we start with the next patient. Okay. We're going to go through all this in clinic too, and so you'll see how to set this up and break it down. It'll make more sense when you can see it, but I'm just going to kind of talk you through it in this lecture. So you're going to barrier the unit so it's protected. I prefer that you leave them inside the white cart. That's why the tops scroll back and forth. Barrier that control box only if you're going to leave it sit out or if you're going to be touching it. So barrier at least the power knob. Place the foot control. We have foot controls for ours, so place that foot control on the floor. And always use your non-dominant foot when you are using the rheostat. And I know that's difficult, but I want you to get into the habit of that, whether you're polishing or whether you're using an air polisher or an ultrasonic scaler, non-dominant foot should be operating the rheostat. Barrier your handpiece. Okay. Barrier your inserts. Make sure that you have all the inserts barriered at the beginning that you may want to use. Bleed the air from the line prior to inserting the tip. So you're going to hang on to the tip, you're going to press on the rheostat, and you're going to wait for it to fill up to the top with water. Once it's filled up to the top with water, we're going to drop our insert down in. But you have to have water inside that handpiece of the magnostrictive before you can drop those magnets down in there. You're always going to start with your power in the blue area. Tenacious calculus may require a little bit higher power, so then you're also going to have that specific insert that is appropriate for that. You're going to adjust the water. You're going to adjust the power in the water until you see a steady stream of rapid drops and an aerosol with a halo effect. So again, I'm going to show you all of this, but you want to make sure that you have enough water, but not too much water. So we kind of have to find that happy medium. Now, some critical thinking. Why are we going to use this? We're going to use this if a patient has some heavy supragingival calculus. And we may use the beaver tail for that. Okay. Maybe my patient then also has some deep perio pockets. Well, then I might need my slim line to get deeper down in the pocket for that. Unless, but I'd have to turn my power down a little bit. So maybe I want higher power for my supragingival calculus. If there's a furcation, so I may need to find a furcation tip and I may need to get inside there. If my patient has periodontitis, if they have heavy subgingival, I'm probably going to want to use a universal or a thicker tip so I can get it down in there a little bit deeper. If they have heavy stain, okay, it's going to save my hand if I can go over that heavy stain with an ultrasonic scaler. Okay. If they're sensitive, we need to figure out why they're sensitive. Okay, so are they sensitive because of water temperature? Are they sensitive because of power? And do they need anesthesia? So do we need to get them numb before we use the ultrasonic scaler? Okay, so how do we prepare our patients? Well, you're definitely going to look at their medical and dental histories. If they have respiratory problems, if they have an old pacemaker for their heart that is not shielded, if they have caries or significant recession or communicable disease, we're not going to want to use our ultrasonic scaler. Okay, respiratory problems, because they, we don't want to make that aerosol and make those worse. Pacemakers, if it's shielded, it's okay. If it's unshielded, it's not. And if there's a lot of recession, we want to be very careful with that because it's going to be sensitive for our patients. And communicable diseases, we do not want to make those in aerosol. And caries, so be sure and add caries to this concern list because we don't want to use caries, or we don't want to use the ultrasonic scaler on a tooth with severe caries. And now, absolute contraindications. We cannot use it on demineralized areas. We cannot use it on the veneer itself or a crown itself, but we can use it apical to the crown margin. So just slightly subgingival. We don't want to have it on the porcelain area of the crown or gold area of the crown. We don't want to use it in areas of extreme sensitivity, and we do not use it on children. So first you're going to explain the procedure to the patient. Explain to them why you're using an ultrasonic. And you can do this when you're explaining your treatment plan to them. I always ask my patients, so we develop a signal so I know if they need me to stop. So I usually say, if you need me to stop for a second, raise your hand. Okay, but don't say things like, oh, it's possibly going to be sensitive, or this is probably going to hurt, or you might not like this. So don't get them negative thoughts in their head. Just say, I'm going to use this instrument. It vibrates, it squirts water. If you need to take a break, please raise your hand for me. Okay. So like I said, just explain to them that all that is going to happen. So ways to reduce sensitivity. I said, educate them. Tell them what's going to happen before it happens. If they don't like the noise, maybe they can bring some earphones. If they don't like the water, let them hold the saliva ejector. Sit them up a little bit so it doesn't go to the back. Maybe turn the water and the power down a little bit if possible. Or we may need to get them numb. Okay. And always make sure it's on your treatment plan and you get consent to use it. So the procedure itself is going to require knowledge of root anatomy. So like if we're using our piezo and we only have the lateral surfaces that are active, then we need to know exactly how we need to adapt that to the tooth. So adaptation and activation, as well as our expected healing responses. So we need to look at our patients over our health. We may need them to use a rinse at home afterwards to help with healing, but it may make their tissues just a little bit sore. Okay, so positioning. So the positioning of the unit is going to be placed on the opposite side of the operator. The operator or patient positioning is going to be very similar to your fundamental positioning. So you're going to sit in the same place as you would to instrument typically. I mean, it can be altered a little bit because the instrument is doing the work and you're not. But in general, we're going to use the same fundamental positions. It's going to be altered a little bit too because of that water control. So you may need to sit your patient up just a little bit. Okay. Come up with a sequence. So treat the mouth in an orderly sequence. So, and that also needs to go by what you've treatment planned. So today, if I've treatment planned quad 1 and 2, then I would ultrasonic quad 1. I would go back to quad 1 and go through with my hand instruments, and then I would explore to see what was left. Okay. I would complete quad 1 completely before I would move on to quad 2. So keep in mind that the probe depths and calculus detection when you're developing your treatment plan. So, maybe you can only do one quad at a time, and maybe we need to get them done or numb. So we're only going to do quad 1 and 4, okay? Because we only want to numb half of the mouth at a time. Definitely follow your treatment plan and think about where disease is present for your patient. Like, what would they benefit from removing first? Always make sure they do that antimicrobial rinse. Slightly elevate them and make sure you adapt your tip to the root surface. Here's your grasp. It's going to be a very light pin or modified pin grasp. If you hold that instrument too tight or push it against the tooth too tight, it is going to deactivate those vibrations and it's not going to work as well. You can drape that cord to avoid drag. So kind of like when you learn to polish, if you learn to wrap the cord or trap it with your knee, basically just to take off a little bit of that weight if you need to. You don't have to drape or drag the cord. As far as fulcrums, extraoral is going to be recommended for the maxillary posterior teeth, intraoral for mandibular posterior and all of the anterior teeth. And I'll go over some fulcrums with you guys when we do a demo, but they're pretty similar to your fundamental fulcrums as well. So how do we do it? How do we insert it? So you're going to position it like a perio probe. So you're going to keep that toe pointed apically and the toe third adapted whenever the tip is subgingival. So you're going to activate the instrument, meaning you're going to push on that rheostat as you slip that tip subgingivally. You're going to keep it positioned as a probe on the direct aspect, so that's the direct facial and direct lingual. You're going to use it like a curette on the interproximal areas. So you'll also hear me say like tap, tap, sweep, tap, tap, sweep. And that is like you're going to be tapping it subgingivally and sweeping to the next area. You're just going to keep moving, keep moving, keep moving. The water may aid in more comfortable insertion as well as flushing out that bacteria. Okay, so when scaling supragingivally, you're going to adapt that tip and use multi-directional strokes. Okay, so it's not going to be as specific as when you're sub, because sub, obviously we can't see where we're at. Supragingival, you can. Okay, so you're just going to move that around constantly. So remember we said that it is highly, the power is the highest at this very end, the 2 to 3 millimeters at the end. So we never adapt that tip at a 90-degree angle to the tooth surface. Okay, so it is the most active, that very tip is. So we are not going to ever put that against the tooth. So never adapt the tip at a 90-degree. The terminal shank orientation and basic principles of instrumentation is what we're going to follow. So too much lateral pressure is also going to result in deactivation. So you have to have that light grasp, constant movement, never the tip directly on the tooth at a 90-degree. So the power is concentrated in the last few millimeters of the tip, but all surfaces are activated for your magnostrictives. So it's going to be a real light grasp. You're going to keep moving. We're going to gentle apical tapping motion against the deposit. So you're going to walk around the tooth. So keep that toe pointing down or up, depending on if you're talking about maxillary or mandibular. Okay. And you're going to angle it into the caul. Still, that tip is going to be pointing apically. So you're going to use a generalized back and forth, sweeping, multi-directional motion. So again, you're going to hear me say tap, tap, sweep, tap, tap, sweep. Okay. We're just going to kind of constantly keep moving, but you're always going to want that toe pointed towards the junctional epithelium. You're going to use overlapping strokes, continual movement of that tip in all different directions. So that tip must contact the deposit directly in order to remove it. So if the tip does not come in contact with the calculus, you're not going to remove it. So take care not to repeatedly go over, like carry over the surface of the deposit. You don't want to burnish it. So you want to tap, tap, sweep so it can shatter that piece of calculus, not just keep shaving layers off until it comes to the point where it's just a small bump on the tooth that we can't remove. So you must access the depth of all pockets, including that interproximal, which you may have to switch tips. So maybe that thick universal tip won't go interproximal to the base of the surface or to the base of the pocket. So then you're going to want to switch to a slim line so you can get in there a little bit better. We prefer direct vision. Okay, the mirror tends to hold water, so it is going to be a little bit difficult to see, but I'll show you some tricks on how you can put water on your mirror and some other ways that we can help a little bit with our visibility. But vision can be difficult. Okay, so completion. So hand instruments are always going to follow the USS to remove those remaining fine deposits and smooth out our rough edges. Okay, not demineralized areas, but rough areas from calculus. So always, always, always hand instruments after USS. So USS, then hand instruments, then explore to see what you have left. Gracies are going to be appropriate instruments, definitely after we use the USS. And then if you want to go back in and if you've removed some more pieces and you want to lavage again with your USS, that is perfectly fine. And then we're going to usually end with our polishing, right? Because that's what our patients think makes everything clean, is the polishing. Now, post-appointment care, warm saltwater rinse. And if they need to take something for the discomfort, I always tell them to take whatever their doctor tells them they can take for a headache. So depending on their health conditions, depending on their other medications, some people can take ibuprofen, some can't. Some people can take acetaminophen, which is Tylenol. Ibuprofen is like Advil, okay, and some people can't. So always say whatever your doctor recommends you take for a headache. And then always go through good OHI with them, because now that we're getting them all clean, they need to start doing their part at home to maintain. Okay, post-appointment infection control. Rinse the insert under water and dry it, and you're going to place it in your cassette. We don't ever put these in the ultrasonic cleaner, okay? The ultrasonic cleaner is going to be really hard on your magnet strips. So never, ever, ever put those in the ultrasonic scaler. Okay, then you're going to autoclave those tips. We always need to make sure that our lines are dry. So make sure that you remove all the water from your ultrasonic lines, just like you remove the water from your air water syringe at the end of an appointment. Okay, we don't want those biofilms being created in our lines. Okay, now aspiration and evacuation. So this is like the high vac in our saliva ejector. So this is what's going to remove the fluid and other materials from the mouth. So the HVE is going to make it possible to pick up fluids. It's going to pick up materials without bringing the tip of that evacuator into contact with the fluid. Okay, so the high vac is very powerful. You have to be careful that we don't get attached to tissue because it can do some tissue damage. So the high velocity evacuation, or HVE, is the best if we can use it with the ultrasonic scaler, because it's going to be the best to remove those aerosols so we don't breathe them. Okay. So, and it's best if we have an assistant, and you want to keep it away from soft tissue. You always want to have your high vac on hard tissue. So your saliva ejector, that's just your normal saliva ejector. It's going to be placed in the corner of the patient's mouth. An assistant can hold it, the patient can hold it, the operator can hold it. We can show you different ways to bend it so it just hangs there. There's many different other things you can attach to your high vac. It's like the first leaves. There's different ones that we'll talk about. If you hold it yourself, use it, help you use it as retraction, so it can help pull that cheek back too. So retraction, tissue shielding while using the ultrasonic scalar air polisher. So if we can keep that cheek pulled out, that helps keep the aerosols in the mouth. So gently pull that lip out or cheek out to form kind of a cup, and that's going to help keep those aerosols within that patient's mouth as well too. And it's also going to reduce the amount of water that's going to be spraying out of the mouth. Okay. The HVE is going to eliminate the need for the use of a cuspidor. I don't even know if you guys know what cuspidors are, but they used to be on all dental chairs, and it was just a ceramic bowl that your patients would sit up and spit in. So we didn't use the saliva ejector a lot. We would let the patients just spit in this bowl. And they've kind of gone by the wayside because they're dirty. No one wants to clean them, but that's what a cuspidor is. The HVE is going to, or HVE or saliva ejector, either one is going to make it more comfortable for the patient. It's going to make it easier for us to see, and it's really going to help with our infection control. Okay, but it's best if we have an assistant because it's easier for them to use the ultrasonic. How are we going to hold that HVE? Palm grasp. So that's thumb to nose grasp. So the palm is going to be wrapped around that HVE with the thumb pointing towards ourselves. So it provides greater stability when retracting that soft tissue. Okay, you want to try to stay away from, just try to keep the tip of the HVE away from soft tissue. You're going to want it on hard tissue if possible. Okay. You can also use a pin grasp. That's going to be similar to the grasp of an instrument, not modified though. And that's more effective when you have a surgical tip or a really thin tip. So place the tip as close to the working area as possible, but again, on hard tissue. So avoid contact with soft tissue. You will create damage. So it will leave like little broken blood vessels on the tissue. Our HVE tips have a hole in one end. That hole should be out, not inside when you put it on, and I'll show you how to put it in for sure. Why? Because that helps as a little vent if you're caught on tissue, so it helps eliminate a little bit of that tissue damage. So place the edge of that tip even with or slightly beyond the occlusal or incisal edge of the tooth. Place the tip slightly distal, okay, because the patient's laying down. Gravity is going to bring that fluid back, right? So make sure that that patient is laying down so that fluid can go back and into the saliva ejector. All right, so it's important to review the health history so we can determine if we are even going to use the ultrasonic scaler or not. And we definitely have to make sure that we control those aerosols. So we need to keep ourselves safe, we need to keep our patients safe, we need to keep other patients safe in the clinic. But using the ultrasonic scalers are going to make it a lot easier with our difficult patients, and it's going to help our patients stay healthier.